Só deixa eu ver o slide. Eu só não quero ali na apresentação. Não usei slides. Tenho medo de slides, claramente, depois passo. Mas tem aqui o PC. Ok, só mesmo. Vamos seguir está. Só um pouco. So good morning. Our apologies for the delay. It was my fault. I would like to welcome you and to present my special guests. Doutora Maria Blancozeira was the former health minister in Portugal, probably, or by sure, the most important and competent minister of health of Portugal.
It's so kind.
In women. And because I was also a former I am a man. José Mendes Ribeiro is a very experienced and important health consultant and a person with a huge responsibility in health management in different hospitals, organizations, and he's also a teacher of the European University. And he's a very good friend, so he has a very broad vision about the health system, more, I should say, more open to market and less public vision. It is important to share with you some advices and visions about the Portuguese health system. So I would like to know each of you, but before that, how we will be organized this morning. I will spend with you half an hour showing the main milestones and the topics about the Portuguese health system organization. And then the most important is to share ideas and to have the occasion to talk with you. I believe you also French? No. Not yet. Toujours que j'ai l'opportunité d'être avec des personnes de la Roumanie, j'imagine que vous parlez le français. Vous parlez français?
I can understand what you want to say it, but I won't be able to answer.
It's a scandal.
Parce que nous sommes Portugal et nous sommes nous avons la racine linguistique et j'aime beaucoup. Parce que c'est l'une des plus belles langues du monde. Donc, si vous avez l'occasion de faire des questions en français, je pourrais merci beaucoup. Parce que j'ai un ami qui, à ce moment-là, est le président de la municipalité de Lisbonne, c'est Carlos Moedas. Et l'autre jour, il me disait que nous, moi et lui, nous aimons la France parce que nous sommes vraiment macronistes. Bon, let's go to the Helbian language. So, could you tell us your history, your name and your history?
I'm a general surgeon.
No, Dragos, second. You are a surgeon.
I am a surgeon.
But you work now in the Ministry of Health.
I still work hospital. I work in the Ministry of Health as a state secretary. I was appointed to state secretary during the pandemic. Then I returned to the hospital. And after a year, when Minister Rafila, the current Minister of Health,
Is a
took
doctor?
office, is also a professor of microbiology. I had a very good relationship with him during the pandemic. He was a microbiologist. I was the government state secretary. So we collaborated during that period. And when he was appointed minister, he asked me to become his personal advisor. So I did. So for 2 years now, I'm a personal advisor.
But normally you work in your hospital and you do
I
surgery.
still work.
And you did
And
not
in the
forget
afternoon,
the way
the
how
afternoon
surgery
I-
was done.
In the afternoon, I go to the Ministry of Health and I deal with the resilience and recovery program and all the reforms regarding the resilience and recovery program.
So, thank you very much. As you see, we have a very interesting group and we can, after my half an hour introduction. Now, your name is
Livioka.
Liviu.
Yes. I am a professor of bioethics in the University of Medicine and Pharmacy, Lorete Popa in Iași. I'm also the president of the College of Physicians.
You are a medical doctor also.
I'm a medical doctor and I am a dental doctor.
And you teach bioethics
Bioethics.
in Bucharest?
Now in Iași,
I mean,
it's one of the university centers in Romania. And I'm also interested in not generally in bioethics, but in public health.
I'm Mugur.
Arduino, Elias, Elias.
No,
Yes, is the name of the hospital.
I'm grateful for him, but Mugur, this is the name of the hospital. I don't know how address.
You are a doctor.
I'm a doctor, I'm a surgeon also. I worked as a surgeon for 30 years.
General surgeon.
General surgery.
You know the-
Mostly digestive.
British guys, our friends, so it's from the UK, say normally that the general surgeon now must be renamed by residual surgeon.
Well, okay. Their opinion. I worked as a surgeon.
So you are a practical doctor. You work in the hospital.
Not anymore. They tricked me about 7 years ago when I became the hospital manager. Now I'm the
You are in the
manager
business area.
of
You are the manager of the hospital.
yes. It's a 900 bed emergency hospital. This is what I do now.
Good morning. Wait, je parle français. Je m'appelle Cristina Lupan. Lupan, oui.
Et vous travaillez
Je
au
travaille aux
Institut national des services. Voilà, docteur.
I am a doctor. I teach in the last 20 years, let's say. I try to help those who try to become managers of the hospitals or chief nurses or, I don't know, chief of services to understand the idea of health management and to apply the principles of health management. Organization, quality, finance, things.
Perfect. And finally,
Georgia.
because the other colleague is on board, 2 weeks ago, you are always present. I know, so.
My name is Georgetta.
Sorry?
Georgetta.
Georgetta.
Yes, like in French.
It's like you tell Georgette.
Georgette.
It's
Georgette.
Armenian Georgetta.
And you work in the same
I am
institute
the
of
same.
Christina, you are colleagues, you are a doctor?
Yes, I'm a medical doctor by background. I worked in the rural areas. Beginning of my career. And then I have also
And now
second
you are-
specialty.
Suddenly you are in risk.
Yes.
Outras pessoas são
Somos brasileiros.
brasileiras. Eu também falo brasileiro. Bom dia. Muito bem. So, welcome to the most beautiful city of Europe. I don't know if it is your first time in Portugal. Yes. So, please go to Caixo Toré, Lisbon, Medina, Puerto Alto, and we'll have tomorrow and the day after tomorrow 26 degrees here in Lisbon. We have the most beautiful light of all European cities because of the river. We have a reflection of sunshine, so Lisbon is well known in Europe, the city of the white light. And the prices are quite good,
Yes.
even for your wallet, because we have the same, I think we have the same income in average, Portugal and Romania. And so please go to Cascais, my residence land, so I live in that area. It's beautiful, beautiful place, and
Perhaps to suit that.
and Sintra.
Sintra for sure.
And last but not least,
We are going on Sunday.
we will have here a morning of practical discussions, less slides and more discussion. We can talk in the language that only in Romania is not possible because we don't.
You will understand,
It's quite
really.
good.
You will understand. Maybe we speak slowly, you will
It's like
understand.
with our friends of Spain.
Yes.
Si hablas despacio, in Spanish, we understand Spanish people, but Spanish people don't understand Portuguese. So let's go. We are talking about the Portuguese health system, half an hour, some global picture ideas, and then the opportunity to share a debate with Maria side and Trevine, asking more in the institutional public views, because Maria is one of the most respected and considered personality in the field area, in the health field in Portugal, with a very sustainable thought about what is health policy, what should be health policies in health systems. And Maria is more a practical, operational civil manager. She's a man from the ground and defends the more important presence of private sector in the health system, freedom of choice. So she's quite a liberal. You are now, Portugal is running the election. And we are now celebrating in the 74, in 2024, the 50 years of democracy in Portugal. And we'll have the opportunity at last to have the extreme right in our parliament, probably in third place. So this is fantastic. That is fantastic because we did not expect that surprise, but that's life. So we are a small country, not one of the smallest countries in the world. As you know, we are 27, and probably we can divide Europe in three parts: big countries, the medium countries, and small countries. And Portugal, and I believe Romania. You have how many people do we have in Romania?
19 million.
19.
So you are almost in the field of the big ones. So these are the big ones.
And the medium.
So you start the medium term until Sweden, and then we enter in the small countries. So we are in the average of the European Union, 10 billions, and we have now 10% of our population now is not national. So Brazil is taking account of Portugal. We discovered Brazil in the 15th century, and we gave the independence to Brazil because Brazil was our most important colony in Brazil, 19th century, and now they are taking account of us, they are trading, and probably in 10 years we'll have more Brazilian people here in Portugal than Portuguese.
The surplus Portugal, I think, is a county of
Yes, Portugal is the size of the metropolitan area of São Paulo. But much more safer. If you go to Caxias, the probability of you return to the hotel with your wallet is 95%. And in São Paulo, the probability of you return to your hotel without your wallet. So, small country that gave new worlds to the world. We have discovered in Africa, in Brazil, in Asia, so Portugal is a small country that discovered everywhere. Portuguese is like a plague. Portuguese people, because you find a Portuguese guy in every part of the world. If you go to the southern of Australia, if you go to Tasmania, if you go to, you find a Portuguese. Probably a driver, a businessman, or a hairdresser. But fantastic people, you know? You are...
Once in Parliament, if you will, once in Parliament, you received the foreign office, East Timor. And
former colony of Portugal.
The first words he said,
Indonesia.
please do not forget that your house in the east is Timor-Leste. We are at home everywhere.
If you go to Japan, if you go to Asia, if you go to different the Arabic Peninsula, in every place of the world there are military constructions of Portuguese, because Portuguese is quite an epidemic people that is all during different centuries spreading all over the world.
So the 2 million population misleading.
Outside, we have approximately 3 million. So really Portuguese people with birth in Portugal probably will have 12, 13 million. After that you have the second generation and the third generation. We already have senators in the United States of America from Portuguese origin, and we have in France lots of municipalities with Portuguese
And in the US.
representatives, senators in the United States.
Also have some 4 million Romanian.
You also have a very great, how do you say in English, diaspora?
Yes.
Yes. You are like us, people of the world.
Same one.
But you are going more to Germany, no?
Go to France.
As doctors, France is the first country of.
Perhaps for you interesting. We have international world, not only outside but inside, because our genetics in Portugal are
Mixed.
Not so mixed as the Brazilian one. Because if you go to Brazil, you don't find any genetics, typical genetics, because they are a mixture of blood.
nationalities.
But Portuguese, we have the influence of the French, because we were invaded by French in the 19th century. We have Arabic influence in the south middle of the peninsula, Iberia, Portugal and Spain. We have the Southern Vikings.
Sim.
So we are
And
a
we have
very...
Indians and we
Indians.
have black people and we have Mexicans.
It's a cocktail, a genetical
It's a-
cocktail. You are
very
much
good
more...
one.
No. But we were at the border of worlds between Russia, Turkey,
A confluence of
Austria,
the...
Hungary.
Of course.
I've never visited
Austrian
Bucharest,
Empire.
but probably at the end of this meeting, you let your visit cards, and we'll invite our three of us to go to visit your hospitals. I'd like to go to Romania. So let's go. Small country with a very ancient history. The country in Europe with the oldest limits in geographical terms. So the borders of Portugal are the oldest borders in Europe. because we only have a neighbor. That is an advantage, Spain. And we were invaded by Spain in the 16th century, and they occupied Portugal by 60 years. And then we sent them again home, and since then we live together side by side. But the borders of Portugal are the most the ancient ones and the oldest ones in Europe. Second point. Do you know what is the oldest political alliance in Europe? Political and military alliance. It is the alliance between Portugal and the United Kingdom against France. Because the UK guys, they don't appreciate, they don't like French guys. And by questions of colonies, we have some agreements with the United Kingdom, but we like very much the French. So we had a crisis in 2010, 2011. You have almost the same crisis, the Lehman Brothers crisis in the United States, and then the southern countries like Portugal, Spain, France, Italy, Greece, and I believe you also. We suffered a lot with the international financial crisis in 2010, 2011. Since then, we recovered, and now our GDP is well. And we closed last year, we were in the Europe 27, the country with the most impressive growth of the economy, 2.3%. So we are recovering from this crisis that we lived in that sorry, tenho que atender esta chamada, mas já tem. So the Portuguese health system is a beverage model health system. It was a copy of the UK system, created in 1979 by a Portuguese health minister that stayed in place only 3-4 months, António Arnaud. But he was there. Sorry, I released that
Doctors have to be always on.
Excuse me, you are all doctors?
No, I'm a lawyer.
No, you are. I'm economist.
Doctor, public health doctor.
Different skills.
Was talking about the minister who created National Health Service, but he was not able to do that while he was minister, only in Parliament, because our Constitution commands that this kind of public facilities have to be responsible by the Parliament. Because we elected rights.
The decision-making process was born in the parliament.
Yes, it can be proposed by minister.
Sorry.
Then it has to be approved by the.
So António Arnaud was in job 4 months, and he was that fixed idea of letting the country with public health service structured and inspired in the British models. As you know, the British NHS was founded in 1948 after the war, and the Portuguese health system was founded 31 years after, in 17. So it is classically, as you know, the Sweden, Finland, Denmark. In Europe, if you look to the map of Europe, all the countries in the border of the geographic limits, north and south, have NHS systems. Finland, Sweden, Norway, Denmark, UK, Portugal, Spain, Italy, Greece, And in the middle, you have the Bismarck models, which references in Germany. So we probably remember Bismarck was a chancellor of Deutschland, and he created a model that is very well appreciated by Mendes Ribeiro. This is the model more structured in active people and less in the condition of taxpayers. We will see in the debate there is pros and cons in both models. If you go to the NH models like ours, you have probably more efficiency, but more waiting lists and less freedom of choice. If you go to the Bismarck models, you have more expensive, more expenditure, but you have less waiting lists and more freedom of choice. And then José António Mendes Ribeiro will talk soon about that. So, the National Health Service integrates all the public institutions and also in its scope agreements with private and social entities. You know, so you have the NHS, the Portuguese NHS, but not all providing services are public, because I can, by the NHS, contract with private and social entities of service citizens, and the payment is made by the state, Portuguese state. And then we have in Portugal now a very significant and important part of private sector. Private sector in Portugal grows significantly, and now more than probably 4 million. We have 10 million, 4 million of people have a second or a third coverage. The public coverage everybody has, because it is universal. And then we have people with health insurance, and we have some people with subsistence like civil servants, military people that have another coverage, so they can use the public service and also the private service of coverage.
Half of our population has another coverage besides the public, the NHS.
So that is good, but that is also not so good, because from the point of view of the citizen, that allows more freedom of choice. I can go to the public hospital in the afternoon, I have a second opinion, and I go to the private doctor. But from a macro appreciation or a macro point of view, you inflate the expenditure, the total expenditure, because you spend money 2 times. You are contributing with your taxes to the NHS, and then you are paying an health insurance or another coverage. So the ideal will be, and José António mentioned, I think we'll talk about that, to have a unique way of financing, and people can choose the possibility of going to public facilities or private facilities without any additional expenditure, or an alternative, having some discount in taxation, because families are paying 2 times or 3 times. That is not fair and generates inequalities, as you probably know. So, we have, this is my last slide for the introduction, because I want to go to the stage, to be the stage to explain and generate this. I have more slides, but I will show them at the end, and Joana also will send you by email. And if you wish, we can go to Bucharest and deliver personally the slides.
We will wait for you in June as we organize EMA.
In what date?
From 5 to 7 of June.
4?
5 to 7
Yeah, 5 to 7.
of June.
Okay. So I will invite you, because I am the chairman of the big event here. 31 May, the 1st of June, the Skies International Health Forum. And this is a Friday and a Saturday. You should be present, and I will invite all of you to be present, because it will be a very interesting event, international event. And then we have lunch in Cascais on Sunday, in package, and we'll go to the office. So, the National Health Service ensures integrated healthcare to all citizens, national or not national. If you have the condition of national resident, you go to the NHS, you don't pay anything. Now we have a problem. The papers this morning say that we are under pressure because we have 1 million of immigrants coming from other countries, workers, people working in service, in restaurants, in agriculture. They are using the National Health Service, and we have also rich residents, Americans, for instance, that uses our NHS because it's more efficient than the healthcare in the United States because they have lots of money and it's free. So that introduces some pressure in the conditions of working of the NHS. It's free of charges, so if you have an incident, I hope not a very good stay in Lisbon. For instance, you are going in the afternoon, you go to Cachoeira to have a very nice meal of fish and a very, very good restaurant, and you break a leg. You'll have the 112, the national number of emergency. You'll have a very modern and well-equipped ambulance, if necessary with a doctor on board, and you'll go to hospital, you will be treated, and you will not pay cash.
We are European citizens, and we have European
citizen
insurance
card
also, yes.
But it is not necessary, you know,
Yeah,
in some
I know.
countries you are obliged to pay at the entries a fee, something, small value, but a fee. Here you are not obliged to do that, and the UK is in the outside the European Union, and they have the same system for European citizens.
But with Romania, they have an agreement, like
A
years ago,
bilateral.
that the bilateral agreement.
If we are in Bucharest, well, one of us in Bucharest, and we have an accident, you go to the hospital, you don't pay. Yes, it's the same. Okay, so we can go to Bucharest without any problems because we will be treated. The National Health Services promotes equal access to its users. So we have the problem. We have a small country, but we have problems in the rural part and urban part. It's the same all over. If you live in Lisbon, you have a kind of conditions. If you go to the Évora or to Guarda, indeed, the more rural part of the country, it's not so easy to access to services. But this is equal, I think, in France, in Bulgaria, Romania, all the countries, they have the problem of the urban parts comparing with rural parts. And finally, National Service works on a regionalized organization. Until the end of last year, we had 5 regions. Now we are implementing a new reform with local health units, and we have 39 local units integrated hospitals, primary care physicians, long-term care, and the idea is to have 39 small NHS with more autonomy in terms of management and financing by capita, not by line of production. And this is quite technical, from a technical point of view, it is interesting. If you wish, we can discuss that. And this is for the introduction, this is the global view, the global picture of the NHS. And now I propose that with José and José António Mendes you can do your statement, introduction, if you want, do your best. And then I will moderate a debate between this part of the room and your part. Thank you very much. querem começar? Querem começar?
Well, good morning, everyone. I hope you feel very well among us. And I don't know if you have any question after this summarized context that Robert gave you. Perhaps I could say that since the creation of the National Health Service, of course, our health position is a very good one compared with all the developed countries. Europe, mainly because of the space, geographic space, we have the best health indicators. Anyway, as everybody, we have a huge problem with inequalities from one point of view because of social and economic conditions. And we need to work nowadays in a different way, not only for health ministers looking at the national health system, but working with all the government, trying to develop the conditions of living and working of all the citizens. Because when we have a close look at the different ways that people benefit from a national health service, a universal one, and without payment, of course we have to see and to be confronted with the different life expectancy years, life free from disability, and of course in a country with economic problems as Portugal has, we have here gaps that health policies have to solve or convince the whole of government to work together intersectorally in order to solve. When we look at the life expectancy, they are very high level. But when we look at life after 50 years old, free of disease, the landscape is completely different. And of course, with the fiscal pressure to finance health systems, if we don't act at prevention and at promotion, of course, we will have a huge problem because if we spend everything we have as budget with disease, it will be very difficult to incorporate innovation and to make all the things we want to attain the best levels of health we can obtain. So I think that the most important problem nowadays is that one, because it's very influenced by, as Professor Adalbert told you, we have a very ancient alliance with UK, and we have a National Health Service that is a copy from the National Health Service in Great Britain. But for public administration, we have a French model, because it was spread for Europe as perhaps in Germany, I don't know well your public system. And this model is a vertical one. So each one treats about their territory, and we have to be now integrated to look at the nowadays problems, to be intelligent and to allow people to attain all the potential of health that they can attain if we work together and if we look at the conditions of life, the quality of work environment, the quality of housing, all the things that are so important for the health results as well. So I think that this is the huge problem, and all the international organizations or agencies we work with, and we work also, I think, like WHO, OECD, and others. Nowadays, they underline the importance of making the main target of our action to look at the health of people and not only at the disease of people. So I don't know what you think about this. Is the same thing in Romania? What are you doing about it?
If you, yes, I'm sorry to interrupt you. I would like you to participate to put in lots of questions. Don't be shy about you can put all the questions. As you know, probably
And disagree.
we politicians, we only answer to the questions that we want to answer. But the problem is not the questions, it's and I suggest that after the brief presentation of Marie and then José António, we open a dialogue and you put concrete questions, point by point, because we would like to contribute to our staying here with some practical information and not to give a classic presentation of slides.
Can I ask a question?
Yes, please. Please put your question.
What were the main problems that drove you to the change on 1st of January?
Why did you change the five
system
region system
from
with the
5
39
regions to
regions?
Talking about the organization.
What were the main issues that made you to change, to make this major change?
I will give the floor to Linda. Probably I will explain that I was with 2015, and the present executive director was my former secretary. And the plan that he is now implementing was written by me in 2015 in the program of the government. I have some differences of opinion because the University Hospitals have been that they integrated in local health units. But the idea is to integrate. The key word is integration.
And the keyword are integration and some freedom management, always depending on the consent of finance. Because during the financial crisis, different rules were adopted and contract for health people to work in the hospitals for health centers and so on had to have the signature of health finance minister. So this is absolutely impossible to manage such a complex and appeal to immediate action system, waiting months for someone that we need to replace another one who went to
There was another practical, this is very important because the southern countries and the Latin countries lives in what I call the bureaucratic democracies. We are bureaucratic democracies. We live merged in rules and departments and papers and powers, quite different from the Anglo-Saxon countries. But the idea we had until the end of the century, we had 3 networks separated: primary care, hospital care, long-term care. And the idea was to merge that and having only a manager. The management council now, from 1st of January, rules and manage all the 3 types of cancers. So you can organize, and you theoretically you eliminate the tension, the competition between three levels of power: primary care, hospitals, and the war, the tension existing between primary care physicians and hospital physicians. There is a traditional tension because hospital physicians believe that they are superior and better doctors than primary care
Who
physicians.
inspired the model? Sounds very innovative, integrating on the vertical layers of service. Where did you find inspiration? From what country?
Yes, northern countries, Finland, Norway. So if you look to Europe, the countries with most important experience in integration are the northern countries. And in Spain, we have some very well succeeded experience in the
Autonomous regions,
Valencia.
Valencia.
Ribera, Salud. There are some good
Organize the
experience.
whole country without piloting sounds very risky.
Yes, I agree with you. This is the reason why I have criticized our government and my ex-former Secretary of State, because our plan in 2015 was to do in 3-4 years with a pilot. But at this time, we don't have the finance liberty because we are trying to reduce the leverage of the rate in debt, public debt. So we don't have money in the health ministry.
So in
And
3
now-
years, we should do again a meeting and the
Now,
results.
this is risky. You are quite right. Risky, and then we have elections in 10 of March.
But we have to say something before, because you don't know, but I am a very ancient health minister. So I was minister 95 to 99, 4 years, and in the last century. And when I looked the landscape of health, the main problem was the disintegration of the system. Because if each one of us has to look for the health services they need, this is not good. So the system has to take care of us, and that's why I experienced different models. And this model of integrated care with only some management of primary health care and hospital care was experienced. So it was one of the things that was made. So
Sorry, when did you, this local health units integration is just happening, when did you?
in the north of Portugal, in a new hospital and a new organization of health
I did
centers.
not understand. Repeat your question.
No, the minister said that you experienced the benefits of this
We
integration.
had since 1998 4 local health units working. So we have
it
some
was
experience.
Some kind of pilot, you said
Yes.
it's no pilot.
Yes,
Now, in this model is quite different from the old model. So, and you know, we
for
really like
local units with limited populations and for,
only one of them is important. It's not huge.
yes, but it's a local hospital, it's not a hospital with reference capabilities, because at the same time we began developing a network of reference units in order to make
But your
this
question,
system.
I understand. Our friend is asking if you were, or if you had 4 experience since 1998.
Right?
No, 98 is the first one. But
The first one and the
others
other
are
ones.
recent, are more recent. Should it that be enough to fulfill the criteria of test, the pilot test? I said no, because the present model is different. And the present conditions of working in health is quite different from 30 years ago. Now you have prices of medicines, you have innovation, you have problems with workforce. So we are not running an operation with the same principles of the best of 1990s.
And you have different hospitals like those involved in the National Doctors, and so they are quite different, and if they have reference capabilities, they have to
With a dangerous budget.
have a different model of financing,
As I understood,
not only.
your best hospitals are also included in local health units.
Yes.
And this is a problem. You should have some umbrella.
Because university hospitals are
for the
national,
country.
are not local, are national, reference national reference. And you know, the three most important university hospitals in Portugal, when you create a local health unit, you have a budget of 1 billion. 1 billion of budget. This is insane and dangerous.
That was my
Your question and then the
too.
presentation of the
Sorry.
the private.
You said that this local health unit has more autonomy. I mean, they can manage on all aspects of the management of the unit without any, I don't know, approval from other superior
It's a kind of
levels.
decentralization of funding.
Yes, they act with a budget, and inside the budget, of course.
They can
have
hire, they
much
can
more-
fire
yeah.
personnel, they can
It's
make
the-
purchases, they
it's
can
the model.
change
It's the
the
model.
structure, they can.
This is a dream. This is a dream. Because in 2016, I made a press conference with my colleague of finance, Mario Centeno. I was the president of the Eurogroup. And we, with the pomp and circumstance, we announced to people that from that date, all the hospitals will have budgets approved and they could work with budgets, with autonomy. And then, you know, in healthcare, it's a principle in administration, public administration, and public finances that says never a minister of finance should ever give autonomy to public entities. So, they sign the paper, all the journalists may send pictures, and then business as usual.
It was not true.
Financing on capitation.
That's why I am
Sounds very
talking about
dangerous.
different levels of control.
When you have
because
freedom of
times
choice,
change.
you have reference hospitals. Finance, sorry, I want to ask you about financing on capitation. How do you feel about this? When you have, clearly you have a maldistribution of infrastructure and doctors, so clearly some local health units will be much better than others, and with the freedom of choice, I understood you introduced in 2017, people can go to Lisbon, to Porto, to wherever those local.
Referenced by the family doctors.
So even though the money can follow that patient,
Yes.
it's a tiny portion. You are financed by capitation, so population based. So the money from that for that patient is peanuts. Yes, because it's not enough.
Yes, because
to
it's
finance
assessing
the
with
hospital that-
different levels.
Of course. So in Bucharest, for example, 50% of the patients in Bucharest are living outside of Bucharest. So Bucharest hospitals are overwhelmed, and the regions in
Districts
in
around.
are deserts, are medical deserts. Because Bucharest is draining everything, also the patients, and also.
We face a similar problem.
But the financing, our financing scheme, the more patient we have an insurance-based system. It's not a danger for the hospitals in Bucharest, because if they do more, they receive more. But financing the local health unit on population
If you must,
The activity will
the law reviews compensation items, so the capita is not the same. And the advantage of capitation is to introduce adjustment by risk, by disease risk and by population risk. So probably in a city in Portugal, in the rural part of the country, like Guardas, you have a capita, a better capita when you compare proportionally with the capita of an hospital. So, but let's state here a thing that you agree with us.
I root for you, I mean, I want you. And I am very interested in the results.
But let me,
Of course, they are beginning a new model. We have to wait to see and to try to compensate and adjust all the problems that emerge from a different way of working.
let me put some ice rocks all over our heads. Let's not be romantic. Let's not be a dreamer, because utopia does not exist. In every country in the world, we'll have always problems of inequalities between rural parts and urban parts. We'll have always doctors that want to work in Lisbon and then want to work in Guarda. We'll have the most important facilities will be in big cities. This is all over the world. There is, in the world, all over the world, you don't find a country that resolves the problems of inequality. You can minimize it, you can minimize them, but you cannot resolve. If you choose to live, if you choose to live in the interior, in the rural part of Romania, it's your choice. You will not have there a transplantation center. You'll have the transplantation center in Bucharest.
But you have to have a transportation, put you in the center.
Not
with
from
the-
this point of view. For example, in Romania, we have a problem in rural area that the population, because the lack of general practitioner, lack of other specialists in ambulatory, they all go to the hospital, let's say in the last moment, when the disease is acute, and they die, let's say.
Welcome to the paradise.
So the problem is there where the hospital has no tool to change these habits of the population. So they have to make a lot of services, a large number of services for diseases that, according to a capitation and even a risk adjustment for that disease,
Two ways. One is quite costly. It's education in
It takes 50 years.
Times it takes 50 years. You go to the school.
no
and,
problem, but it takes 50 years.
young children and start to learn that it is important to go to the family.
If you maintain this
Second,
expression.
most important advice is correct incentives. You know the theory of incentives? Yes, the theory of incentives is that if you have money, you don't have problems. You pay this doctor to go to the rural part of Bucharest to install a very important clinic, a modern clinic with a complementary ancillary
We
diagnostic
tried
tests.
this by World
you
Bank
said-
and it didn't work.
You said to your people,
In
to your patients,
95,
that they
96.
don't pay anything in the consultation of our friend, and if you go to the hospital, they pay 50 euros. Incentives. That costs political
No,
votes.
we had a project through World Bank.
You lose elections, you lose elections.
We had a project through World Bank. We tried to make, let's say, very new clinics and with everything equipped.
And they
And
go to the hospital.
nobody went there, I mean physician, doctor.
Money, money, money. As the song of the ABBA. Money, money, money. Please, your
I
question.
have a question. I'm fascinated about integration. So really, I've read a lot of things and I have a question. So basically, there is a stimulus or initiative at a general level, macroeconomic, to do this kind of integration. But if you look to the literature, they say integration not necessarily because they have chronic diseases and because in a chronic disease with different specialties, and somehow we'll have to have doctors organized such a way to provide everything from screening, prevention, and then curative and rehabilitation. So my question here is how this integration, which is at the micro level, will promote this kind of organization at the micro level.
Please, this is my last statement because I will back to José Antonio is going to take this as a part of his speech, I believe. Normally, I say to our students in this school that the health systems all over the world, in the big or in the small or the size, are a pyramid. No? So you have in the first level primary care, and you have in the last level sophisticated care. And when you talk about a system, this is a system. A system is something that is organized. That is references. You have some sequences that you must fulfill to raise and to go up in the different levels. So you have in this system that is a pyramid, you have political options that could be exclusively public, that could be public, private, or social. And where you can have a very large level of freedom of choice is here. In the first level, in the basic level, you can allow every people to choose a doctor. And this is my banking account manager. He treats with me my health status and my own life. And I have a problem in bladder disease. I go to my family doctor, which is who is a private one. He works in the private sector. And he told me, now you need to go to the gastroenterology. And I will refer you, I propose you to go to the hospital of Cascais. And with an electronic and digital references, I go directed to the second level, and I'll go to the hospital of Cascais, referred by my physicians. And then I am stepping up the pyramid, and at the end of the day, I have the need of a lung transplantation. And lung transplantation centers are at, as you could imagine, are in the top. Here, it is not possible freedom of choice. Because in Portugal, we only have 3, Lisbon, Porto, and Coimbra. So I live in Algarve. And my family doctor in Algarve told me, you must have a lung transplantation. You can choose. I would like to refer you to Lisbon because I know my colleagues in Lisbon. I have confidence in them. But if you want to go to Porto, I will refer you to Porto. And money follows with me, the public money, because if I am naturally referred by the hospital of Cascais,
Transplants, I believe, is more complicated
no,
than referrals.
No, the referral. I just say we have free centers, and probably the patient will accept.
It's a transplant list, a national
Yes.
transplant list.
Okay, but
Criteria.
this is an extreme example in order to say that in the top you have the most complex option. But here you have neurosurgery, for instance. This is the reason why I don't believe that in any organized health system it is possible a total freedom of choice. It is impossible. Because you must organize the technical responses with quality. You could not have in Portugal 20 centers of transplantation of liver or lung. You must have 2 or 3. The other thing is that politically, he decides that this center is managed by a private operator. This is a political option. But that does not allow the idea of having freedom of choice here. It is impossible. So here you could have freedom of choice. You should have referral principles. and you doctors are referring patients in subsequent levels in order to cope quality with efficiency and respecting as possible the wishes and the preferences of patients. But as you're going up in that pyramid, the freedom of choice is diminishing. So this is a system, local or national. And then you have finally the political option. You could say that is exclusively financed and provided by public entities. Paragraph. This is a model 100% public. The other option is a mixed model, and you can have finance, public finance, but the providers can be some of them public, some of them private or social, but they are obliged to work in this mainstream and in this framework. You understand? And the third option is all of that is private. But you cannot dispense, you cannot let down the idea of a system, an organized system, because you don't have quality if you leave these old providers
Do what they decide to do.
doing what they want to do, because you'll have excessive care for some people and deficit care for other people. And this is a public responsibility, it's not a private responsibility. Here, you must have the government of the country saying that, okay, we agree all that in Portugal, Romania, UK system, the health system is a pyramid, and now the financing and the organization, we will see if it's public, private or social. Please, my friend.
Only to say something. This is the field area in politics that is closely linked with sovereignty area, because it has to see life and death. And sometimes people do not think about it. If in public side we lose the strategic conduction of things, we are losing the possibility of control the very delicate area that is the area of life and death. And I can give a very simple example of what succeeded in Portugal, for instance. During the 70s and 80s, we had the fiscal problems and very huge problem in financing the development of public service. And for instance, dialysis was almost only private. We paid the highest prices in all the world to treat our kidney insufficiency. It's so simply as that. And when they wanted prices go higher, they went to the main place in Lisbon with caixões de cofres, não é? Caixões. Como é que se diz?
Were they Portuguese firms or Fresenius and Brown?
Fresenius and Brown.
Everyone, but
Davita.
represented by the patient association of kidney diseases.
Yeah.
So this is not
95%
this
of
is
that
not a
is
simple thing. This is not
But they can
something.
ask the price.
When they wanted, they decided the private enterprises.
For
When they
example-
wanted to make prices even higher, they used the patient associations to go to the main.
Pressure.
To make pressure.
Okay.
But very
In
high
Romania, we
pressure,
also have
very
private
impressive
providers.
pressure.
But they have to complain to the law regarding the price they get. They cannot get higher than it's written in the law. They are private.
But what
negotiated
law?
here in the framework contract.
Yes, it's a
They
law.
were
For us, it's a
there
law.
is no
It's a
law.
regulation.
There is no law
In Romania,
for
we have
politician
laws with
people when you have all these patients that have an emotional presence near the population, the global population, say we are going to die because government that do not accept what they need, and it is a very important decision and so on. And so this is not simple.
Yes, I
So
understand.
if public health system do not have strategic competence and services, they are in the hands of all the pressures that can be made, mainly in these areas that are core areas and very important for life and death.
So you nationalized the dialysis?
No, we did not nationalize. We invested in dialysis units in public hospitals. It's always as that. We do not need to nationalize.
So you have now 40
These are international groups, but we have to have this capacity in public hospitals. So I can buy outside things that are important, but I have to have some capacity in public units. Otherwise, I won't control prices, you know? So this is not a very romantic view. It's a very pragmatic and not pragmatic, objective view. We have that problem in Portugal. That's why, as Professor Adalberto said, Mendes Ribeiro is more liberal than we are, but he agrees with us in these core issues, because we have to look at this with not only pragmatism, but with justice, because we are dealing with money that people delivered us to give them better health. So it cannot be managed anyway, just because it's very nice to have a liberal vision.
I have a question. To some extent, there is a liberal vision even in this, I think. I mean, if you
It can be more or less.
more or less, yes.
More or less.
But if you look to claim by capitation, and I understood the idea that capitation is adjusted with the health risk, but still, when you fragment it, the financing in different regions, and they are decentralized, which I think is good for innovation, for everything, the risk for adverse selection in those areas increases because there is a smaller group of people, and of course, if something happen and there are very many people become sick of very costly diseases, you might have this. So my question is, who will do this management of negative selection? Because if you have to manage these funds locally, those people should somehow do this kind of
calculates the risk
Of course,
and who assigns the risk. for each
complex
region.
system
What
as a
institution?
system has to be constantly monitorized, of course, and we very
why
much rely on digital transformation
Do you
in order
have
to
enough
have the
data
control
calculate-
system
really
that
calculate risks?
can give us some.
if you look
I don't believe they say yes.
because if you look to the system, it's like, I mean, if you look to a kind of, take an example from America, and there is Kaiser Permanente, which is a kind of private healthcare system, which combine insurance system and also medical facilities. Well, to me, there are similarities, but of course they are big, quite big. I mean, if you
And
look,
they are the most expensive
they're the most
system
expensive.
in
This
the
is why-
world, living
And they're
40
the most
million
expensive.
people without.
Because they have monopoly in many, many places. But these funds will have these funds will have a kind of monopoly in a place. I mean, I'm not sure I understood very well.
Let me
No?
point of
No,
your
okay.
discussion,
Yeah, also.
because the problem is the financial.
Of course.
When I left the government in 2018, I had 9 billion budget. And at that time, the Portuguese health system was considered the most efficient of the EOCD. Now we have more problems of cancers, and we have to double. This is the problem from the political point of view, is the lack of control and the enthusiasm of people that are designing and implementing reforms, and they are not sensitive to the problem of the public experience. So it is dangerous when you compare Kaiser Permanente with the local health units in public systems, because the fundamentals are different and the ways of dealing. If you are a private manager, you have certain kind of rules. If you are a public manager, you have others. So, and we deal with, and finally, we must listen to Montreal, but we deal with lots of oligopolies and monopolies, pharmaceutical industry, medical devices, dialysis that
Medical specialists.
medical specialties. So we cannot be have ingenuity and to be so light, so romantic, thinking that we take a paper and we design a reform, and we don't have experience of dealing with money, because during our lives we had only experience in public sector with the father and the mother of the Minister of Finance giving us some money, and it's a problem, the aging, the innovation, this is a problem. And I say there, probably in 2030 left with 50 billion, because the aging and the innovation and the problems of diseases. And I said, it's calm, because I pay 52% of taxes per year.
So
And I am not,
that's it.
and they because they are also rich people. I am not available to support that, because this is a crime. In Europe, there is no other country in 27 that raised the expenditure from 9 to 8.
But to pay attention without any reform, things
Actually, there was.
still like before pandemic.
You know the language and thought of public officers, public managers. The problem of aging. People are getting older. Yes, it's true. People are getting with more diseases. Yes, it's true. They organize lots of workshops about the chronic disease, managed disease, and then they are paid by the pharmaceutical industry to organize another symposium, telling that drug is better than this one, but that is 300 times more expensive. This is quite catastrophic. I am joking with you, naturally, but this is the point of view of a political responsible, that sometimes we don't have money, and you are facing the other side a certain degree of unconscious and saying that there is no limits for the budget. You don't have oil. You have oil.
But coming from behind, there is still room. Yes. So we compare ourselves where we come from the bottom of the sea in terms of financing. Yes. And our budget also increased by 10, 15 to 20%
What
each
is
year.
the public budget that we have now?
So the total health expenditure in 2019 was
Public
65.
and private.
Public and private.
Out of pocket, it's only estimation of 20%.
And public budget.
The rest of public budget was 50 billion lei. It's 10 billion euros. Now it's
So you have twice of the population,
yes,
Yes. and you have half of our budget.
yes.
Welcome to the problem.
Yes, but
of
this is after a yearly increase of 10 to 15 to 20%. So we come 10 years ago, our budget was less than €1 billion, so we have a huge increase because we come from the pits of hell, yeah? So, I follow data every time. So in Europe, there was many years a 10% increase in each country, but it seems in the last 10 years that it capped somewhere at 4,500, 5,000 euros per capita, per inhabitant. Yes, total health expenditure. You are less than half from that. We are 7 times less than that. Yes, so coming from behind, when the costs are the same, the drug costs, the materials, the electricity, the gas, everything costs. Just the workforce and the salaries differ between Portugal, Romania, and France and Germany. But in medicine, we don't. In medicine, we don't speak about those economic indicators with how much is the cost of bread and the small things. We talk about high-end materials, and these are not included in the general economics. Yeah.
Mr. Professor Adalberto is joking. I'm not a dangerous private sector defender. I believe we can work together all the 3 different players.
I never said that.
We have in Portugal, the social sector is traditionally a big provider of care. We call it Misericordia. So they are a big player, and they are focused in some of the most important home care, providing home care services, providing the different approach. Even in the primary care, they are very important players. So I think we can, in the provision of care, we can have different solutions with the private, with the public, with the social players. And our experience last 10 years, we did a reform with the introduction of PPP, private public partnerships, and this experience was based in 4 different projects, 4 hospitals in the north, in the center. This experience was very interesting because after 10 years, we saw the higher satisfaction of our citizens. The prices, the budget support by the state was lower, and we have good results in terms of quality. Mr. Adalberto, please.
Hospitals with public management, with private management, with public-private PPP, owned by the government. So it is not necessary, even the money financing is public, you can give inside the system, these are private operators.
So I think the government must design the system. Now we are facing another reform of politics, and comment on later. But the players could be different players. And it's very good to have different players because we can have a benchmarking and always improving the answer and the quality of the system. So, in my opinion, it's better to have more diversity, we have different players doing the job, because it helps to have better results, better outcomes, because we can measure different approach. You talk about Kaiser Permanente. I visited some years ago Kaiser Permanente in the United States, in the area of California, and they have 9 million people. We are, in the whole country, we have 10 million people, and they have very, very good outcomes. The system, they introduced some years ago the concept of HMO, the American HMO, and that's what we're trying to do now with this reform, with local authorities and also local provision of care, joining primary care and the hospital. But we think, and Professor Adalberto will talk about it, we need to assess effectively if we can do this reform at the same time for all the regions of the country, because we need to have different answers. For instance, for 5 hospitals, big hospitals, we are in the system, probably 40% of our budget is used in these hospitals, and we don't know yet if, as you told, the capitation is useful when those hospitals have half of their patients coming from different specialties and the different areas. With the model of capitation, the financing these local health providers is not so good as I think they are pretending to be, because as Minister Adalberto is explaining, for instance, in the north of the country, the PPP approach of Braga was a city of Portugal. The hospital was designed to attend 1 million people in neurosurgery. But the hospital also was prepared to have the answer for 600 million people for gastro, and 300 million people for thousand for general surgery and so on. So our network of hospitals, we need 10 hospitals to answer to neurosurgery. We don't need them. And we have no enough doctors or trained people. We can do it.
So we won't have 39
yes. So, and more we have problems with.
We have a national reference, and this is defined, okay?
This is
And it is
compulsory.
important, sorry to interrupt you, it is important for all countries to have the mainstream design. And to have these rules must be designed and well defined. Because if you have only market answers, you have a problem of excess of quality.
Expertise.
Yes. So this is the model. The other thing is who will be inside the model. You can have private, PPP, Google private, and only public, and you must have inside the pyramid managed competition. And you must put them in competition each to another because you take some advantage of this competition. But you must be well disciplined. If you don't have discipline, you'll have the chaos.
Can I?
Sorry.
Please. Ladies first. In Portugal, we have the rule, the old people, not the young people. But the old people have a rule, ladies first.
Speak about competition. Let's see. You spoke about competition. In Romania, we have this problem. All the private providers try to compete for a limited sum from the health insurance fund. Because the health insurance fund pays for the private providers a very limited sum every year. And they try to compete a lot. It's very demanding among them. They try to get as more as possible from the National Health Insurance Fund.
And think of quality.
The problem is that they get money from the health insurance fund, then they also charge patients for different, let's say, hotel and yeah.
Wrong system.
Thank you.
You must persuade your government that it's
in Portugal, they are not allowed to charge the patient.
No.
Sometimes, no. They are not allowed, but if they can, they produce private agreements, not the big groups, the professional groups, they don't do that. But in some operators, they have, with some vulnerable people, the health insurance only gives me 100 euros. I need to use a special device. That company does not. That means
That's why regulation.
I am a social liberal, so I understand that the state must fulfill basic needs and to protect people against the impulse of liberals. In health is quite dangerous, the impulse of market, because people tends to have more money and they can commercialize medical practical health assistance. So the advantage of beverage models is that when people go to medical assistance or medical care, people must not pay nothing. Potentially 5 euros, 10 euros for a moderate tax. Because if you introduce money in the personal relationship between provider and patient, you'll have a problem. And even with insurance, companies are quite strict and they control that. If they know if the provider is taking money outside the agreement, they expel this provider from the network of insurance. But the basic rule is that in private financing or in public financing, when you are ill, when you have an accident, you have anything, not pay nothing. You pay before we are paying our health system because we pay taxes, we pay VAT, we pay.
Actually, I'm more fond of the insurance. Because, okay, it's one of
with
the
rules,
but the other, but there are many disadvantages. Lack of competition. Waiting list, as you said,
yes.
And in the NHS, there are,
yes.
I mean, I have friends in
that
come back to Romania to get treated and pay back, because otherwise in 2 years they are yeah. And you see the problems in NHS with doctors. Doctors are truly unhappy. And all the personnel is unhappy. And so I believe countries with social, ours is something, I mean, we have on paper a social insurance system, far from the truth. But countries with real social insurance,
Let me
like
give
France
you-
and Germany,
I agree with
Let
are
me give
much
you
better
a
than the
magic
average.
solution.
Of course, the wealthy countries in the north, they have social
Let me give you, all of you, a
differences.
magic solution. And we give this option even to the Portuguese leader of the opposition party. This is the NHS in Portugal. And he announced it. He announced it. We have the NHS. You must take into account that the critical variable are doctors. Doctors must be comfortable, happy, and well paid. You know? And so, in this model of local health units, I designed and write in 2015 model of CRIs. This is special high-performing units in public hospitals when doctors work more and they earn much more. So this is a way. They are accelerator units inside public hospitals. If you have a hospital of Cascais and you have waiting lists, you can activate the CRI model. And the surgeons work at the end of the day, and at Saturday they work more, they earn more. And we have now, in the public sector, doctors earning per month 15 and 20,000 euros per month. Do you follow me? It's important for you. We have now, without an accelerated system, we have in public hospitals, doctors earning per month 15,000 euros. So, but let me add some to your concern. If, even so, I have waiting lists, we have a rule, a law that I revised in 2017, the maximum waiting list times of eye disease, cataracts, eye surgery. Imagine 1 year. I live in Cascais and I have a problem of eye disease. I must go to surgery. And the time is finishing. 1 year is passed and Cascais Hospital did not call me. I am automatically empowered to go to another public hospital or to a private hospital with agreement with state to do my surgery. And who will pay this surgery? The Hospital of Cascais, because it generates inappropriate waiting time lists. This is
to take the train to.
Yes,
there,
this is a perfect system. You are giving the incentive to the public hospitals to not to have waiting lists, because they generate waiting lists, they will pay to the patients outside. And you allow public hospitals to pay doctors much more than the flat salary. And then,
But they
You
have
can.
the budget to pay the doctors.
yes, and then now you have the levels. Nowadays, we have hospitals paying 12, 13, 15, 20,000 euros per month to doctors. In hospitals now, today. And the other day, I talked with the principal, the CEO of Lusaúde. CEO of Lusaúde is the biggest private hospital group in Portugal. And she told me, I am concerned because the public sector is spending lots of money and I am losing doctors that want to stay here. They want to come to work in the private sector because here they have other facilities. They have time to go to congresses, they are not obliged to control the time, they are not pressured by private managers. So this is a difficult balance, sorry to interrupt.
No, the experience Spanish did with Ribera Salud, they have a budget for the health unit, but anytime one of the patients go around to buy a service, the hospital pay, because they assume If people need to go to another
They are
provider,
Side,
They are
they are failing.
they are failing. So they are
They have
obliged
to
to
be
pay.
punished.
And
Unless they don't have the specialty.
No, which is different.
They are failing. For people, it is indifferent because I could not be blamed by your hospital don't have the specialty. It's not my problem. I have the disease. If you don't have the specialty, it's your problem. I have the disease. If I have the disease, my hospital covers or doesn't covers. I pay taxes. Let's talk with it frankly.
Yes,
It is a
but why to
permission.
punish the hospital? They cannot have that specialty.
It is a problem with the hospital with the state. The state must authorize the hospital not to be punished because they don't have the specialty. This is another thing. They are in the level 3 or the level 4. They don't have neurosurgery. They must not be punished because in the contract they
No,
don't
you have a contract each year.
And when inherited infrastructure is not like, now everything is perfect and everyone should be perfect.
We have a contract, we have a defined level of service. You have, you are obliged to contract with some level of.
We call that
services.
we call that the wallet of services. If you have an hospital in that level A, they are not obliged to have neurosurgery. So they will not be punished because they are not in the wallet of service contracted with the state. They don't have neurosurgery. But you have an hospital of level C, which is obliged to have everything, and they failed with waiting list, they must be punished.
Or if you need an X-ray, you can go another hospital if they don't do it in 5 days, for instance. If they don't level of service, if at every time they don't respect the level of service, you can go.
Is there thresholds, minimal waiting times set by the
Yes.
government for
Yes.
each?
Yes,
Yes.
there are legislation
Since
was
my-
made started with legislation
Starting
and
with
are
me.
reviewed in 2007.
And the
Can-
financing
can
of
we
hospitals
get a copy of
is
this list?
contractualized every year.
I'm going to.
And another question, we probably have, let's say, something like national programs for specific
Yes.
disease, yes?
Yeah.
Okay,
And
okay. How much in terms of percentage the national programs represent the expenditure from the health expenditure, 30, 40,
programas
50?
são para aí 3% ou qualquer coisa.
Doutora Joana,
Correto.
I want to send the law with maximum 10
The national program from the
Give
total
me your
expenditure is
email,
3%. I will,
But for public policy, not for delivering care.
For everything.
For everything, we don't know, because we have, se puser o programa da HIV, se puser as diferentes coisas, I don't know, but this is maybe 20%.
As I was telling you, since government, the budget of hospitals
This is a
is
deal.
no more.
Yes.
It
I
starts
wrote
from-
in
It
the letters,
has to be contractualized
D,
with the competencies. If you have HIV services, of course, you have the specific financing for that
This is
share.
that is this.
And it's always discussed on statistics.
Okay, confirm me if you receive this.
Demand for care in that field. So this is not fair negotiation. We have information, we have the historic demand, we have the provisional demand, and hospitals negotiate with financing entity that is a national one. The budget they are going to have for
no,
next
I was
year.
thinking in the total of the healthcare expenditure, how much weight the national
Yes, I
programs.
cannot say you know, because I don't know the numbers specifically, how
30,
much
20, 30, 50.
HIV represents in the global
Not
expenditure.
each program, just, like, but in the idea that we're going to pay per capita, how should the national program integrate?
Because
Because if the national program says per capita,
And it's
Well,
the
we-
same kind of
according to
payment.
the
It's
number
per
of
capita
persons
for all the
they have.
services per capita with the national program, how they are going to fit in this?
According
it's
to the
a
number of
curiosity.
persons they have.
Because if we really have information and data about the
Sorry to interrupt you. I'm going to send you the national reference network that was made also in 2000. Best two ministers in Portugal will be. And all the very good legislation is between 2015 and 2018. I will send you. I revised all the very good legislation that we raised
Because
some years ago.
has to be made
In Portuguese, but all in Portuguese.
There were-
yes.
there were 2 moments of good things in Portugal. And the dolphin. The best in town.
Do you know the amount of? all
Do you
the-
want to have a coffee or do you want us to
No,
continue?
the,
Have you got to a coffee?
it's higher than in your country. It's about 30%.
30%.
30% do nosso out of
Yes, yes, one of the worst out of poverty.
And the medicines are really low price, very low price. We have
Yes, but they represent
Yours-
the very high.
Do you have an
price that
HTA?
the private
Do you have an HTA system or the same external referral system, differentiating system as for prices in?
Yes, you have it. I will
Who do you
send you all the
differentiate?
legislation of 2016.
We began it.
It's easier
We
if
want
you
to go
answer
to a
than to
coffee.
research in the legislation.
Let's take
Probably is of the laws, is to implement the laws. We want to have a break for a
Yes,
coffee.
yes.
fazer cafezinho.
Também fizemos os ligamentos, foi tudo em 2016, 17, 18 and 15. You have a very good booklet of laws
With inspiration of the language.
with the inspiration of manipulation. If you want to recommend your government some good writers of laws, you can give our guys.
Yes.
my daughters, yes, Facebook is for old people. And I answer them, I am part of old people.
Yes, it's for people around 50.
They use now Instagram.
Instagram and the youngest use YouTube. Because they like images. YouTube and TikTok.
Yeah.
TikTok.
Obrigado.
And the intellectual segment of people, Twitter,
Yeah.
now is X.
Yeah.
Yes. Okay, let's go. So, right?
Okay. I didn't understand quite well what Sr. Alberto told me. I think this session was will be focused on the future and about the challenge our systems are facing. And at this moment, precisely, all Europe is trying to implement a big transformation, digital transformation. So I prepared some slides about digital transformation, because in Portugal with the PRR, you have the same program. Europe is giving us some money, and we are trying to invest in new things.
What is the amount on health?
On health,
1.4 billion.
We have.
oh, very good. We have the double.
But you have the
population.
level of population.
But the central service, which is SPMS,
300 million.
300 million.
For the digital purposes, we have 300 million.
We also have
Out of
400 million on digital.
We have a total of 1.4 billion, and 300, one quarter of this total amount is to
Yes,
digitalization.
to say we have 400 million on digital for.
And supostamente, não.
Não.
Ficou congelado.
Atrás não dá. À frente,
Congelou.
frozen. Ok, agora já deu. We are living the post-pandemic world. We have a lot of lessons from this COVID experience. But what we are really, we woke up with this nightmare, and now we think the opportunity of digitalization is really, really huge, and is very important to prepare our system for other events in the future. So we must profit this opportunity really to do the home work. We live more. Can we live better? It's our question. For the first time in the history, infectious diseases kill fewer people than old age. Anger kills fewer people than obesity. And violence kills fewer people than accidents. I don't know if you know this Yuval Noah is the Israeli guy who is writing a very nice book. And really is surprised. We now anger kills fewer people than obesity. And obesity is a big problem we are facing in our countries. The world is adjusting to new norms brought about COVID-19, impacting all strategies going forward. This was the rationale we use in Portugal to present our program of PRR. What's the rationale? Now we close the pandemic period. How do we prepare for the future? And it's about industry challenges, new human truths, new business norms. We are building a new future. And
Your PRR came with some reforms that you assumed in
Yes.
front of the Commission. And what were the major reforms?
the government don't say
It's not
quietly that, no, for instance, the professional order, doctors, lawyers, and so on, the government signed an agreement with Europe in order to content the level of autonomy of the orders, professional orders, but they don't say it exactly. And now they are facing a problem with this because the process is not so good as they wish. But there are some reforms, for instance, in the education, health, we must invest more in prevention. Some public policies are redesigned. Older people, immigration, and so on. There is some the digital revolution in healthcare is speeding up. So, as all of us know, we have much more telemedicine, predictive diagnostics, wearable sensors, with the 5G in our phones. The 5G is
Yes,
familiar
yes,
with, okay, helps to introduce much more information and speed the telecommunication. So if the IoT, the Internet of Things, all the devices are able to connect each other in a quick way. So there is a big opportunity, for instance, to help people at home. It's one of the big revolutions we will face in the system. Top innovations to achieve more for less in healthcare. The convenient care and telehealth is two of the biggest transformation that digital health will help. The point of care will move rapidly into the home. In the United States, for instance, the two federal programs, Medicaid and Medicare, they announced in 2025, they will have savings of $286 million millions, yes. It's more than our PIB. Billions of dollars.
Yeah.
More of our GDP in savings with oh my God.
Say it in Portuguese, we'll understand.
Em francês.
Não, eu quero dizer que eles estimaram ganhos, poupanças de 286 milhões, levando os cuidados, move the care to home. So, with this transformation, they will save more than $286 billion, which is
Wishful thinking, and it's not gonna happen.
You know, in health policies and health systems and health budgets, we must always dream. We must dream.
No, but
If
they
you
have,
don't dream, you have nightmares. You must dream.
They spend
We
close to
need,
$15,000
we need to-
per inhabitant per year total
we need to-
expenditure, 3 times than every country in Europe, so it's not.
You are talking
the
about the
rational-
United States.
the study is made by McKinsey. McKinsey is a consulting firm. So, and the rationale is clear. They assume then with this experience, for instance, the care in the United States are very high level, and a very level of price is very big. And why do they have these savings? Because 30% of the cost of care are for infrastructure. For instance, our hospitals are built.
I will send
and
you the law made by me in 2018, founding the NHS, the hospitalization in home
at
care.
home.
at home, at home. And now we are.
Today is a session of propaganda.
But that's why we are on YouTube.
But now, with this experience began with Adalberto, we have the equivalent of a hospital of 400 beds. Every month, the number of people assisted at home, it's the equivalent of have a new hospital of 400 beds. That's very good. But the American, they pay usually they have a fund, an equity fund, to buy the hospital infrastructure, and they pay a rent to this fund. And in Europe and in our public system, usually the budget, the state budget, pay the construction of the hospital. But in United States, it's not like that. They use money to exploration, not for construction.
You're right, but there are still money spent by the
Of course,
government
of course.
for health, so I believe you should include that.
Of course, but they say when you move for home, the care, you are reducing 30% of the cost of care. That's why the savings can be so expressive.
The home care,
You have the same problem in Romania because the hospitals are built by through European projects sometimes because they are refurbished or maybe by the government. But this is tricky because basically these are the cost of healthcare services. If you look honestly to the things, in the United States, of course, they from the healthcare costs, they pay everything, including hospitals. So it's moving from one pocket to another pocket.
Well, it's irrational to explain how
Yes.
the savings are obtained.
when you speak about home care, you speak about delivering care through internet, through a digital platform, or
Yes.
personnel going home, like
Person
home
going-
care.
Both.
Personal
It's different.
Personal going home with digital platform.
It's different. Hospitalization at home, the continuation of hospital
Treatment.
treatment. So the patient is not delivered to the community. He is at home, but he is under the care, the attention of doctors and nurses from hospital. This is quite, you have a surgery, light surgery, and you are going to your
We don't
home
have this system.
2 days, but you are under the hospital responsibility at home. The other thing is hospital is the home care. You have a chronic disease and you have nurses and people going.
Should be
The
some
average
minimum
length of
requirements
stay.
for the living conditions.
Yes, I sent you the text of the law.
The average length
And
of
the
stay
results.
is about
Results of the program. Results
9
of the
days
program. So very good
at
one.
all. After hospitalization, some patients can go home, and in our statistics, the length of stay is 9 days, and with these 9 days, they don't need to be in the hospital, inpatient, and they come home, and we save some money, and we have the equivalent of a hospital of 400 beds, I told you.
During this period of time, who is visiting us?
Nurse, and a doctor. Sometimes doctor made the plan of care, and but the daily assess is made by a nurse. But different things is about the health condition, diabetes and so on. Those kind of patients would be included in a home care program. It's not an episode of hospitalization, but it's the way they manage their condition, their disease. And I think in this case, the digital could help very much, because they don't need to be is that physically in consultation?
It's like a telemedicine.
Yes, telemedicine. Because we have a lot of new things from the digital. The big data, analytics and predictive analytics. It is, for instance, the way we can build the capitation, knowing all the data from the population for each local health unit.
But you already implemented without the big data. This is my concern.
Internet of Things, as I told you before, 5G technology, multi-devices connectivity for different conditions of health. We can follow the patient at home, not only at home during the whole day. Now, I have this watch from Apple. It always monitoring my level of breath, my pulsation, heart rate. So very good. AI, algorithms, machine learning, always improving. Yesterday, we were together in a presentation, and I don't know if you know the Kissinger. Kissinger is dead recently.
Just
Henry Kissinger, with 100 years, very, very good. And he had a team, people who work with him, and they produce some knowledge. And one of the last books, 2 years ago, I think, edited 2 years ago, was about AI. Did you know this book? No. And this team, they have a statement about the future of artificial intelligence, and they say it will be a new time of humanity, only equal of Illuminism and Renaissance. It's the world will change. Is a new period of our history with and more we are understanding that's truth, because it's a challenge. We fear what can happen with non-controlled utilization of it's a problem. And another thing, it's about the algorithm. Algorithm is like a recipe to do some food at home. You have an order of the ingredients. You have instructions about utilization, and we are using algorithms for everything. So they are embedded. For instance, I saw from Siemens, they have an algorithm assessing the tomography. And the system detects better than a doctor a focus, a nodule of a tumor. It's really very precise because this algorithm is making a very deep analysis of a lung, for instance. So it's a new approach which help the way we are delivering services.
I have a small question. When you say big data, you mean patient data?
Patient data.
Yeah. And will you have it already?
Some.
Okay. And you can use it with patient data and predictive analytics to calculate those things with capitation. It's just work.
The government says yes.
Okay.
I'm not sure.
No, but this is the idea.
Let's be optimistic, not dreamer or wishful thinking. The advantage of AI is that, for instance, in Europe, all of 27 will harmonize the conditions of medical practice and giving of care more rapidly than we can imagine 10 years ago. So, in 10 years, probably the standards of medical practice in Portugal and Romania and in UK and in France will be equal. Because doctors will be obliged to work under this kind of machines and artificial intelligence. And the hospitals will be different. Will be less physical, more digital, more technological. And you can, for instance, have a patient in Bucharest with a brain tumor being with a local surgeon and a French in Paris guiding the local surgeon.
We already do this in Portugal
For instance, if
breast cancer.
the best surgeon of brain tumors is in Paris, we can have here in Portugal, in Lisbon, a junior surgeon operating the machine, the robot, the robotics, and the colleague from France with
and the patient
First done by Maresco. Sorry, this was first done by Maresco in the 90s between New York and Paris, and Strasbourg.
Now
This
you
was the
have
first
this,
remote surgery.
now you have this kind of support because most of us, even doctors and people like us with some information, we are not correctly evaluating the potential of AI. And it is so dangerous as so promising. We have promises and dangers, but nothing will be as it was when we studied the faculties and the university. Nothing will be.
it's really a new period of history.
Yes, it's the equivalent to the Industrial Revolution at the end of the 19th century in terms of stepping up of the humanity. And
the invention of the wheel,
yes.
of the
right.
right.
So the connectivity will change more and more the world. The IoT, Internet of Things, in healthcare facilities, for instance, in Portugal, we have a company specialized in this area, and they have a good job. I know some refrigerators in the hospitals with blood and medicines and so on. They have some kind of miniaturization, and that's really interesting because one time one of the nurses left the door open of a refrigerator, and they have an alarm, and quickly they close the refrigerator and remove some blood inside if they did it. For instance, the digital hospital, we can share, I think is a challenge for the local units to have the data from primary care with the data of the hospital, because we have not yet a solution for all citizens with their own health data. We are developing the
Personal medical file.
Exactly. And I think it's the most important piece of the strategy of
We had implemented on paper, I mean, we have a digital solution. I think it has more than 8 years ago, National Insurance has this personal electronic file, but it doesn't work. So now through the RRP, we plan to.
You know, the European Commission published
and to have it.
The European Commission published recently approved the legislation about the health data and 1 month ago, gathering the objectives of producing information, studies, so sharing data between countries. But they are now working, and I believe that will be the natural consequence in 3, 4, 5 years. The European Personal Health Data Record.
In data space.
Okay, I am a virtual file, electronic health data record. I'm going to your country, to France, Germany, and I only identify myself, and all the data will be the minimal data authorized by me, will be shared in all the different systems. It's now they are working on it, but the private players, they have. But we cannot have, from my point of view, states must be quite firm in terms of we need a citizen European health data issue, and not one for the private A, private B. No, of course. If I go to a private hospital, I use my electronic data official. And if I go to the public hospital, I will use the same.
So now which country has this already?
Estonia.
Estonia, since 2018, Estonia was the leading. Estonia is a small country. Yes. Estonia has 5 million.
1.5 million.
Is Lisbon, is the metropolitan area of Lisbon.
They are fully.
They are quite advanced, but they are.
You will see.
If you look at our position in digital transformation, in digital literacy,
we are above the average.
Above the
É a única coisa que eu tenho pena de não poder estar agora a comandar essa transformação. Já estava tudo aí. I will like very much to do that at this moment.
And that, attention, sorry to interrupt you, because you are so right. The problem of inequalities, differences between quality of medical practice, results, outcomes. I would like to know what are really the outcomes in bladder surgery in Romania and in Portugal. It's not a matter of sympathy. I like very much
at the moment
of this surgeon of that. It is necessary to have transparency. What is really in Europe the country
The
with
only
best
countries
results?
in Europe that have disease registries are the northern countries. Denmark, Sweden, so not
We
England, not
must-
Germany, not France.
We
not-
must consolidate
So-
in all the countries.
They do have disease registries.
Outcomes.
Hundreds of registry will monitor everything and can provide the big data for analysis and
Even for health insurance, they can buy and they can contract the best doctors because they know that the results of that
We do
doctor is
better outcomes.
But the variation of quality of care, I mean, there are some studies showing this. It is not from clinic to clinic, it's rather from patient to patient in the same clinic. So somehow
But
it's,
you can introduce the control of this bias.
that's the problem.
Yes, you can introduce with transparency, you can say, on average, the outcomes of this hospital and this doctor are that. But we must explain and take it into account that there are some bias. So let's explain what are the bias.
Because it depends on the social position, socioeconomic status and so on.
But you know, transparency is the best thing that
I agree with
can.
you.
The problem is always the ethics, because you are a professor of development. And Dr. Mary Blay is also a specialist in these areas. My concern is that some time we will face a wall, because it's so exciting to have information about people and the health condition, but the limits of bioethics, law, considerations of data protection, you know, this will be a fight between science.
Well, there are many frameworks to analyze things. If you look in terms of protection and so on, maybe you're right, but somehow, if you look in even autonomy, if you look to, it's sometimes you want to protect the individual, and there are some limits for information, but on the other way, if you have transparency and provide information, you increase the autonomy of the person, because the person may have better health and basically better autonomy. So it depends how you look to these things. And I guess a good equilibrium between these two things should be.
there are
understood.
digital solution for everything to anonymize the data to. They
For
just have to-
research, of
for
course.
research,
for
of
research.
No, criminals are always the head of
Yeah, but it's informed
States.
consent of people.
criminals.
Yeah,
I
a
have
lot
some
of people-
information. Sorry, Peter. Yesterday I had a conversation with a friend, with a friend linked and related to the Secret Service in Zimbabwe. And I was terrified. Talk about at the end of the session.
We are public. So, a new future framework for health, future care, future society, future work. There are new approach based on a future society will have.
Beautiful slide.
Yes. No, we can spend all the afternoon talking
Beautiful.
only about this slide. As the foundation of the new system. As I told you before, we are now doing some work on financed by PRR program, and is beginning also the new program for 2030. I think
Yes, the
you have
structural
also
programs.
the same.
We also.
And digitalization of public services, the digital transformation of business and so on are the main goals for this decade, the digital decade. E-health, the European Commission is working to provide citizens with access to safe and top quality digital services in health and care. The priorities, is the same in your country. Citizens secure access to their health data, personalized medicine through shared European data infrastructure, and citizen empowerment with digital tools for user feedback and person-centered care. So they are the goals. We are in the road to achieve in the end of the decade. And as you told before, Estonia is a really success country. They began and they are very innovative, and I think it's an example for all of us to speed up our transformation.
Most important is to make Estonia on two things: the balance of health outcomes, balance of efficiency.
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 100% electronic billing in healthcare.
Billing.
Billing.
No, let me do a little.
They still use cash a lot.
99% of health data
billing
is digital.
documents. Let me part of personal propaganda. In 2017, I passed the electronic prescription of drugs 100% in electronic system. It was 10% in 2015.
Well, it's a very, very good solution made in Portugal. You can adopt in Romania.
You have an electronic prescription
for medicine
without paper?
So the paper.
On paper.
We do not have yet.
It's also an electronic, but still they
have a support of paper.
There's
I prescribe you a drug in your name. In Portugal, you receive the reference in your mobile phone.
Yeah, this is possible, and we do it in Romania.
No, but
I do it every day.
But more important, we have all the solution. So after the pharmacy, in the end of the month, we know what to pay to the pharmacy,
You have
who deliver the
indicators,
medicine,
control.
and all the system is now digital. And we have the data from each doctor. The system was paid in 6 months, payback, because we see a lot of doctors doing some wrong things. For instance,
Now
they do 20 consultations a day, and
we had a center of payments, and the center of payments in the north of the country. First I visited it by the beginning of 2016. I saw tons of paper, tons. You see, imagine, when I, some time after the implementation of the electronic prescription, I visited again the center, and we have small boxes with 3 or 4 boxes of paper. In paper we saved a lot.
Because this system was created in the 90s, the invoices were correct.
Maria Blaine
and at that
fought
time,
and myself employed.
no, at that time, the Commission for Data Protection did not allow even the digitalization of the clinical process in institutions. It was a huge revolution.
We have it for outpatient medicine in Romania entirely electronic, and it's possible right now. The only thing which is not possible right now is for referrals. We still have paper referrals, but I guess it will be possible one day.
On medicine, there is still the green or the psychiatric or that one is
Special
We
prescription.
And European legislation was very important.
so we must speed up, as Estonia did. In Portugal, as you asked before, we have all the program is about 16 billion euros for our small universe. Digital health transition, the service, the centralized service we have in the Ministry of Health, they have 300 million, and digital transition of business is about 600 billion, but this case there is a lot of problems because some private operators can't access to the funds. It's not
Very easy thing.
a very easy thing.
Did you already start the bidding process and
Yes,
tender?
yeah.
And
Yeah.
they are finished? Now they are
No, they are
working on-
finished, they are developing.
We have
We
a
have-
certain delay, we're approximately 6 months to 1 year delay.
We have
also.
17% of education, education
17%?
17. Esse PMS tem 300 milhões e tem 17%.
Probably by the end of this year, we will accelerate because we have administrative and bureaucratic procedures with the Central Court of Accounting Control. So I believe we had 17%, probably by the end of the year, 6%. But we are delayed. Most of the countries are delayed in terms of implementation.
So, digital transformation is busy work now, but we must see all the success cases to begin a winner also in this area. For approach to the digital transformation, the citizen, the relation between the citizen and the system, the health professional and the system, the citizen and professional, and the health bodies and system. There are 4 layers of relationship between among all the players in this game of health. And we are doing some work in each area, and now I think with this experience of local health units, they must accelerate very, very much to create a system to answer in an more integrated way to the needs. Digital transformation. Universal electronic health record for us is really the priority, the maximum priority, because it will induce efficiency in all the system, and have a world-class technology, interoperability, cloud-based operation, cybersecurity are parts of infrastructure. Is fundamental to have a good infrastructure, and automatization of transaction among all stakeholders as the MEDC program, digitalization of prescription and so on, helps. We have our Portugal SNS, means National Service Health, our health portal. At this moment, we can have a lot of information about medicine, about how to interact with primary care and so on. We need much more and speed up, as I told you before. Digital was never about technology, but about using technology to become customer-centric. The technology is not the solution. The solution is to use technology to help our processes. We need, at first, to design, to know what we want, what are the processes we want. And the technology will help us, but it's not the end, the technology. It's to help us. So, at this moment, we are among all our bodies, public entities and all the system, we have a shared and participative framework of digital transformation as a key for the success. Because as we told you before when we began, we have three kind of players in Portugal: the public sector, the private, and the social sector. All three can be together to deliver more quality, better quality, and attend the needs of our people. Thank you very much.
Thank you. Well, we have some limitations of time because our friends asked us to finish by 12:30. I propose that if Dr. Mitchell agrees, we can share presentations through Joanna, and it was really a pleasure to stay and to be with you here. I believe it was quite an informal class, not a classic class. You are all of you are senior people and experienced people. I would like to have your emails. I have already the emails of Nico and Argos. All of you can, through one of them, send me to the area of the school.
Can share the
Yes.
all together.
You can share because I'd like to challenge you for other initiatives. So enjoy Lisbon, enjoy Portugal. We are the third safest country in the world. Safest country in the world. It's quite important. I was, by the end of last year, I was passing the end of the year in Dubai, and I was robbed in Dubai. My citizen card and my banking cards, I was completely surprised because I traveled by all different and dangerous countries, and I have never been stolen in Brazil, in Pakistan, and I was stolen in Dubai. In Lisbon, the probability of stolen your wallet is quite low, but even so. That's why I don't have wallets anymore.
Close your
Pockets, thank you very much. See you soon. And we will share our contacts with you, and it will be a pleasure to share with you some thoughts and experience in the future. Bonne journée. And,
Bonne journée, bon
Ou parlo, tu em português, parlo comigo.